Okay, let's dive right in. When an ischemic stroke hits, a patient loses about 1.9 million neurons every single minute. It's a literal race against time. So today, we're doing a deep dive, a high-stakes clinical masterclass explainer on exactly how we manage this crisis. We're going to trace everything from the exact moment symptoms start, through immediate triage timelines, all the way to advanced mechanical clot retrieval and rehab.
We've got a lot of ground to cover. Agenda. 1. The anatomy of a stroke. 2. The race against time. 3. Acute treatment with clotbusters. 4. Acute treatment via clot retrieval. 5. Calculating the risks. And 6. Prevention and rehabilitation. Let's get to it.
Section 1. The anatomy of a stroke. When a blood vessel suddenly gets blocked, a core area of brain tissue dies almost instantly. There's just no coming back from that. But surrounding that dead core is something called the ischemic penumbra. This tissue, it's struggling. It's electrically silent, sure, but it is biologically alive. And honestly, this is the crux of everything we're talking about today. Every single acute intervention we discuss is basically a massive, high-speed rescue mission to save that vulnerable penumbra before it's gone for good.
So, where do these blockages actually come from? Well, consider the usual suspects for embolic strokes. You might have a cardiogenic embolus that formed in a fibrillating heart, or maybe an atherogenic embolus that just broke off from a plaque in a carotid artery. Either way, the result is completely catastrophic. We're talking about a massive, large vessel occlusion that totally cuts off vital blood flow to a hemisphere of the brain.
But it's not always a massive clot, right? The pathophysiology here is incredibly diverse. Sometimes we see in situ thrombosis happening right inside tiny penetrating arteries, which causes what we call small vessel lacunar strokes. Then there's watershed hyperperfusion, which happens when a severe stenosis restricts flow during a sudden drop in blood pressure. And we absolutely can't ignore the rare genetic angiopathies either. Things like cadasal, which causes these progressive white matter changes, or RCVS, a severe vasoconstriction syndrome that notoriously mimics a subarachnoid hemorrhage.
Section 2. The race against time.
Now, it is absolutely fascinating to see how modern medicine has relentlessly pushed the boundaries of the ticking clock here. Historically, the IV thrombolysis window is strictly capped at just 3 hours. Then, clinical trials managed to push it to 4.5 hours. But today, thanks to advanced imaging and mechanical devices, that window for endovascular intervention has expanded up to 16 hours, and in some highly specific cases, an incredible 24 hours from symptom onset.
Navigating that timeline, though, requires a strict, non-negotiable triage protocol. First up, ABCs and blood glucose. Why blood glucose? Because extreme hypoglycemia perfectly mimics a stroke. Second, you have to establish the exact last known normal time and get a non-contrast head CT immediately. You absolutely cannot give blood thinners if there's already bleeding in the brain. Third, figure out if they fit that strict 4.5-hour window for IV thrombolysis. And fourth, get a CT angiogram to hunt down any large vessel occlusions.
Section 3. Acute treatment. Clotbusters.
For years, the gold standard has been standard IV RTPA, dosed at 0.9 milligrams per kilogram. Interestingly, though, in many Asian countries, a lower dose of 0.6 milligrams is commonly used to lower hemorrhage risks while still maintaining efficacy. But we have an incredible alternative now, tenecteplase. This is an absolute game changer for stroke centers because it's delivered in a simple 5-second IV push. Skipping that cumbersome 1-hour RTPA drip just makes rushing a patient to the endovascular suite incredibly efficient.
Section 4. Acute treatment, clot retrieval.
So what happens when chemical thrombolysis just isn't enough? That's when we turn to advanced perfusion scans. We're looking for a mismatch, essentially a tiny core of dead tissue surrounded by a massive area of salvageable brain, that ischemic penumbra we talked about earlier. Finding that specific mismatch is exactly what greenlights an emergency mechanical thrombectomy, where we physically go in and pull the clot out.
And the whole reason we can even operate up to 24 hours after a stroke begins today, it's entirely due to landmark trials like DAWN and DIFFUSE 3. These trials literally rewrote the rulebook. They proved that the biological state of the tissue, which we can see clearly on that mismatch imaging, matters just as much as the strict chronological clock. Basically, if there's brain left to save, we go in and save it.
Section 5. Calculating the risks. Once blood flow is restored and the acute crisis is handled, our strategy shifts. We have to quantify the risk of a recurrence. To do this, we rely on some heavily validated clinical scoring systems. For transient ischemic attacks, or TIAs, we use the ABCD2 score. A high score there flags a massive risk of a full stroke within 48 hours. On the flip side, we use the CHAD2-DS2 VASC score to dictate exactly when a patient with non-valvular atrial fibrillation is going to need lifelong oral anticoagulants.
Section 6. Prevention and Rehabilitation.
Let's rapid fire through our vascular defense mechanisms for secondary prevention. We're deploying high-intensity statins like atorvastatin or rosuvastatin and enforcing strict blood pressure control, aiming for a systolic under 120. We also start short-term dual antiplatelet therapy for about 21 to 30 days. But here's a really fascinating genetic hurdle. A lot of patients, particularly those of Asian descent, carry a CYP2C19 genetic polymorphism. This literally prevents their liver from activating clopidogrel. So in those cases, using ticagrelor instead is a fantastic workaround to completely bypass that metabolic bottleneck.
When we talk about managing the profound stroke risks tied to atrial fibrillation, direct oral anticoagulants, or DOACs, have largely dethroned traditional options like warfarin. They offer lower major bleeding risks, plus they require zero routine blood monitoring, which is absolutely huge for patients. However, there's an exception. For patients with mechanical heart valves or rheumatic mitral stenosis, warfarin remains strictly mandatory.
And what about those cryptogenic strokes? The ones where an exhaustive workup finds absolutely no obvious cause? Well, we look closely at the heart's anatomy. If a patient has a patent foramen ovale, which is this small flap-like opening between the heart's upper chambers, closing it percutaneously can actually reduce recurrent stroke risk by about 1% annually.
But medicine is really only half the battle here. True recovery relies on forcing the injured brain to physically adapt. Beyond basic DVT prevention like compression stockings, the real magic happens in therapy. Take constrained movement therapy, for example. We intentionally immobilize the patient's healthy side, which literally forces their brain to recruit and map entirely new neural pathways just to move the paralyzed limb. And today, this amazing neuroplasticity is being augmented by incredible investigational tools like transcranial magnetic and direct current stimulation.
Which leaves us with a pretty fascinating final thought for this explainer. Right now, we're mastering the acute preservation of the brain. We are saving that precious penumbra with ever-expanding timelines and these incredible microscopic clot retrievers. But looking forward, how will emerging neuromodulation tools ultimately unlock and amplify the brain's own phenomenal ability to heal itself years and years after the event?